Hello everyone. Today I'm going to talk about thyroid hormone. Here I will discuss about the thyroid hormone, a little bit of the physiology of thyroid hormone. Then we will discuss about the pharmacology of thyroid hormone, and we will go into the drugs which are the act as an inhibitor for the thyroid hormone, right? So normally when we talk about thyroid hormone, we actually talking about the T3 and T4 hormones that we will discuss in detail. These are the pictures. You can understand the anterior and posterior view of thyroid gland, and here you can see the histology of thyroid gland. Actually, the thyroid gland was first discovered by around 1656 by Galen, and they were calling it glandulae thyroidaceae. Actually, the name given by Wharton on that time. This disease was not very much in medical discussion until they found the case of what you call is goiter. It was the enlargement of the gland. So when they first time observed the enlargement of the gland, they thought it is a hyperthyroidism, right? Later, when they gone in detail and found the correct etiology behind it, then they understood this is a disease of hypothyroidism. In 1961, the another hormone has been discovered, which is also secreted by the same gland, that is calcitonin. The gland which is around 30 gram and inferior to the larynx, it is present, but secretes a very important hormones, and these hormones play a very important roles. If you see the below structure, you can find that there is a one cells, there are group of cells called as parafollicular cells. These cells also called as C cells, and these are the cells which are responsible to secrete the, you can see here, responsible to secrete the calcitonin hormone. Because the its name calcitonin because it is used for the calcium homeostasis. These hormones are very much used or very much need by the body for special purposes like development and the growth related actions. If you see this particular diagram, you can understand here one connection has been shown where there is a hypothalamus which is secreting certain kind of transmitters or chemicals, and they are going to act on pituitary gland, and then pituitary gland releases or secretes various other hormones, right? This whole connection of the hypothalamus and the pituitary and the thyroid, you can see on the right side. This is called as hypothalamic pituitary thyroid system. It is an integrated organ complex providing for the regulated production of the thyroid hormone. So for the regulated production, this system works in complex. The hormones cascade is actually the release is actually begin when there is a secretion of a tripeptide thyrotropin releasing hormone, which you can find here, TRH. So actually things start happening when the TRH releases. So this TRH is going to work on pituitary gland, and then pituitary gland will, you can see here, release the TSH, that is thyroid stimulating hormone. And after this TSH, the thyroid gland receives the TSH, and then it start releasing the thyroid hormones. The neuropeptide, this is this TRH is a neuropeptide because it is coming from hypothalamus. The neuropeptide passes down the pituitary stalk to the anterior pituitary gland, right? You can find here it is passing down, and this is a area of hypophysis which is connected with the hypothalamus. So the TRH releases from hypothalamus, comes down to the pituitary stalk to the anterior pituitary gland, and there it causing release of a polypeptide, the thyroid stimulating hormone TSH, right? You can see here this TSH. Now if you see this diagram, this tells the similar story, that in which cases whenever the hormone level goes down, right, low blood level of T3 and T4 or low metabolic rate stimulates release of TRH. So that TRH releases from there whenever there is a need arises, and after this TRH is carried by hypophyseal portal vein to anterior pituitary stimulus, releases of TSH by thyroid troughs. These are the cells present there which releases the TSH. Now this TSH releases into blood, stimulates the thyroid follicular cells. So by this, once the thyroid follicular cells releases enough T3 and T4, this act as a negative feedback mechanism, and the release of T3 and T4 will block the release of TSH and the TRH. So like that, this negative feedback mechanism also works to control the release of the hormone. Here also you can see TSH to thyroid and then T3, T4, and that controls the release of TRH again from hypothalamus. So like that, this system works. Here actually 3 hormones are there: thyroxine, which is also called as tetraiodothyronine or T4, triiodothyronine or T3, and the third one which is the calcitonin. So all these 3 hormones released by the or secreted by the thyroid gland. The hormone T4 and T3 are iodine containing amino acid derivatives. And there is one very important point for these hormones: they don't have any target tissue, right? They don't exactly act on a particular tissue, but they are need by all the tissues of the body, right? Because they are involved in a very important growth and development processes. So every tissue in the body is affected in some way by thyroid hormones, and almost all cells appear to require constant optimal amount for normal operations. Here you can see the structure of thyroxine, and this thyroxine can get inactivated if it is deaminated. Means you can see here it is thyroxine means tetraiodothyronine. Tetra means 4. Here you have 1, 2, 3 and 4 iodine. So because of 4 iodine is called as tetraiodothyronine, right? When you remove the iodine from this, 1 iodine you remove, 2 iodine you remove, so this process called deiodination, sorry. So because of the deiodination, it changes into the different forms, right? You can see below that if you remove one iodine from that, here you see here iodine is removed in this area, so it become triiodothyronine, means only 3 iodines are there. This is another reverse form of T3 is also formed, and inactivation comes by the dissemination, decarboxylation, or by the conjugation of the glucuronide or sulfate. This thyroxine get metabolized or inactivated. This is very important table because this gives the pharmacokinetical difference between the T3 and T4, and these differences are very important because of these differences there are huge difference between the T3 and T4 while they are produced from the same place. If you see the daily production, so T4 is somewhere very high daily production, around 75 mcg, while T3 has 25 mcg only. You can see the half-life, also a huge difference, T4 7 days and T3 1 day only. Another very important point to see, that is the free amount of T4 and free amount of T3, right? So you can see it is only 0.2 to 2.7 while it is 230 to 420. So it's a huge form, means T4 is more present in the bound form and T3 is more present in the free form. So this is very important, these are very important points for the pharmacokinetic of this drug, these hormones. Before going into this, I will tell you some more points here. Here I would like to tell you that the thyroid gland is made up of multiple follicles that consist of a single layer of epithelial cells and cells surrounding a lumen. You see this here you can see surrounding a lumen filled with colloid, right? You can see here colloid containing follicle. So this is follicle all around, in between the colloid is filled. This colloid is known as thyroglobulin, right? So this thyroglobulin is actually it stores the thyroid hormone. Here this thyroglobulin is a very complex glycoprotein made up of 2 identical subunits, right? If you want to know about thyroglobulin, it is belongs to a superfamily of serine hydrolases, including acetylcholine esterases. And here what happens, a complex mechanism has evolved to acquire and retain this iodine into a form of suitable for incorporation into organic compounds. At the same time, the thyroid must synthesize thyroxine, and this synthesis takes place in thyroglobulin. So now this way this thyroglobulin plays a very important role, because thyroglobulin is one which allows the formation of the thyroxine, because it allows the iodination in it. Now we will see the what is the difference between the T3 and T4, right? So you can understand here the thyroid secretes more T4 than T3. So there are very important points I am going to tell you. Thyroid secretes more T4 than T3, but in iodine deficient state this difference is reduced. T4 is a major circulating hormone because it is 15 times more tightly bound to plasma protein. So it means T4 is more bounded form, right, and compared to T3. So T3 is more free, as I told you before also. So T3 is 5 times more potent. Here you can see 5 times more potent than T4 and acts faster. Peak effect of T3 comes in 1 to 2 days, while that of T4 takes 6 to 8 days. Why? I already told you what is the T half of this drug. T3 is more avidly bound to the nuclear receptors than T4. It means that T3 has more genomic characters in it. It bounds more onto the nuclear receptors, so it has a more capacity to modify the genetical level. The T4 receptor complex is unable to activate or depress the gene transcription. About 1/3 of T4 is converted to T3 in the thyroid cells. So this is another interconversion is also there, where T4, about 1/3 of T4 by deiodination converts into T3. Liver and kidney, by where it does in the liver and kidney, and by which enzyme, 5-deiodinase, which called 5-di. This is a type 1 type of deiodinase enzyme. In addition, T3 is generated within the target cells, maybe skeletal muscle, heart, brain, pituitary, and that is by another type of 5-di, which is called type 2 type of 5-di. These hormones contain 59% and 65% respectively of iodine as an essential part of the molecule. So, you know that because T4 has more iodine in it and T3 has less iodine in it, so that way they are there. A second dietary trace element, this is again important point, a secondary dietary trace element, selenium, is also essential for normal thyroid hormone metabolism. Selenium in the form of selenocysteine is a required component for 3 enzymes that remove iodide from thyroid hormone. Okay, for this particular process you need a selenocysteine. Calcitonin is important in the regulation of calcium metabolism. Relatively constant circulating concentration of T4 and T3 are required for normal growth and development and the proper functioning of the neural, reproductive, cardiovascular, gastrointestinal and hematopoietic systems. So, almost everywhere it is equally needed. The recommended daily adult iodide intake is 150 mcg and during the pregnancy goes up to 100 mcg. Iodide ingested from food, water or medication is rapidly absorbed and enters an extracellular fluid pool. Thyroid hormone exert a wide variety of physiological action through genomic and non-genomic mechanisms. As I told you, both these hormones T3 and T4 are having the different kind of roles. So that's why these thyroid hormones are showing genomic and non-genomic mechanisms and influences the metabolism of proteins, carbohydrates and lipids. So very important role, metabolic role of these hormones into the lipid metabolism, carbohydrate and protein. Plays a role in cell morphology, membrane transport, ion homeostasis, oxygen consumption, heat production and so on. So, before going into the biosynthesis of it, I just remind you about the thyroglobulin. You have seen the follicle, which is a surrounding one thyroglobulin filled body, that's a lumen, and in that follicle this all process are going to happen, right. So, this whole process we can divide into the various processes which we call it as iodide trapping, synthesis of thyroglobulin, oxidation of iodide, iodination of tyrosine, coupling of T1 and T2, pinocytosis and digestion of colloid, secretion of thyroid hormone, and lastly the transport in the blood. So, this is the biosynthesis which is happening here. You can see the iodine coming from, you can see iodine coming from here, iodine coming from blood into the follicle. This whole is a follicle, right. This all is a follicle. This one is follicle and this one is lumen. Okay. So here the iodine comes into the blood and get it inside. It has been actually trapped. I will tell you later how. This iodine comes here, and when it comes here, it goes into the lumen right here. Into the lumen, already thyroglobulin has been exocytosed. Here you see in the follicle the thyroglobulin has been formed. Okay, and this thyroglobulin has been drained out in the lumen. Here thyroglobulin is there, right? And now in the lumen, when thyroglobulin is there, as well as, and thyroglobulin has, you know, the tyrosine in it. So that tyrosine which actually helps the binding with the iodine. So this thyroglobulin comes in contact with the iodine, and this iodine get bind on it, right? Here you can see in this area the iodine is getting bind on it. So iodine 1 maybe bind, 2 bind, right? Like that, how many molecule binds on it. Later the coupling will happen. So here after the conjugation, the conjugated means iodinated thyroglobulin will now endocytosed again. You see here, once the thyroglobulin produced by the follicular cells have been thrown out, and then after iodination it is again taken in. It is like you might have seen the when somebody is fishing, so they throw the net, right? So first net is with them, then throw it out, and when the fish has been catched, then they take it back with the fish. So here a similar thing is happening. Thyroglobulin is acting like a fish net, and then iodine have been attached with this, and now again it goes into the follicular cells, and then after that the further coupling of the iodines will happen, and the thyroxine and triiodothyronine will form, and finally it will go into the blood. Now here this is another diagram. This diagram is from the book Tortora. You might have gone through with this before. So here the sequentially you can understand how the things are happening. You see the first point is mentioned as a iodide trapping, right? The first point is iodide trapping. So iodine ingested in the diet and reaches in the circulation in the form of iodine. Under normal circumstances, what is happening? The level of iodine in the blood is 0.2 to 0.4 microgram per dl. But the thyroid follicular cells trap iodide ion by actively transporting from blood into the cytosol. You can see there, from the blood it is being transported inside, right? Now, who is transporting this process? By the one specific membrane bound proteins. We call it as sodium iodide symporter, NIS, sodium iodide symporter. So, this sodium iodide symporter will take this iodine in, right? Now, this iodine will go inside, and there are certain chemicals which are known for blocking this particular iodide trapping, right? So they lately they can be used as an inhibitor also. For example, there are two categories are there: perchlorate, perhenate, pertechnate, and thiocyanate. So these are all the chemicals which can block this trapping. So now this way this particular iodine is being trapped. Now the second point which comes in, that is the synthesis of thyroglobulin, right? Synthesis of thyroglobulin. If you see, the synthesis of thyroglobulin has been shown in the point number 2. Thyroglobulin is a precursor of T4 and T3. Actually, that is going to give you the T3 and T4 later. It is a large iodinated glycosylated protein. It contains its tyrosine residues as well. And these tyrosine residues are actually the potential site for the iodination. about 70% of the iodide in thyroglobulin exists in the inactive precursors, like it is 70% of the iodide in thyroglobulin, they are present as an inactive form, because monoiodotyrosine and diiodotyrosine like MIT and DIT have no clinical applications. So unless until these MIT and DIT are there, they are of no use. So they are a kind of inactive form of it. When these DIT and MIT get clubbed together and they form tetraiodotyrosine or the triiodotyrosine, then they become useful. T3 and T4, not the T1 and T2, you can say. Now it is synthesized actually from the basal portion. If you see the basal portion, these are the basal portion, right? So it's synthesized from the basal portion of the cell toward the lumen, means it's synthesized here and goes into like this into lumen, okay, where it is started in the extracellular colloid, means it goes and start storing as an colloid form, right, and it remains there as a colloid form. And you see one more thing is happening here. When the iodination completes, for example, you see it came here and now here iodination happened. This is all iodinated one, and now this iodinated one came back through the apical portion. This is apical portion, this is basal portion. So from basal portion it goes out, and from apical portion it comes in back into the follicular cells, okay. Okay, now I hope you understood. And now in this process, iodine, already I told you that iodine have been trapped in and thrown into the lumen. Then thyroglobulin has been formed and thrown into the lumen, where this all get clubbed here. The tyrosine attaches with the iodine into the thyroglobulin, and this become as iodinated thyroglobulin, and this iodinated thyroglobulin further goes into the follicular cells by apical portion, okay. So iodine trapping you have seen the synthesis of thyroglobulin, you have seen the release of thyroglobulin into colloid, you have seen the iodination of tyrosine in colloid. And then what happens here, you can see in this particular part here, you see, sorry, you see here, or here. So you can see here the T4 formation is happening. Here T1 is formed, here T2 is formed, here T3 is formed, right? So like that, these iodines comes closer. These tyrosine units which have the iodine on it, they come closer and make a bonding. When they make a bonding, they make it either T2, T3 or T4. So like that, the formation of T3 and T4 happens by combining the T1 and T2 together, okay. After this, you can see the uptake and digestion of thyroglobulin by follicular cells. Then by follicular cells it brings in, right, and when it brings in, it goes in with the lysosomes, right. Then lysosomes break it off and release the T3 and T4 separately, and these T3 and T4 as a last action, you can see down, these T3 and T4 finally released into the blood. Okay, so like that the this whole process completes within the 8 points, right? This diagram also helps you to understand how it happens. The iodine which is outside comes in by the sodium symporter, right? Sodium iodide symporter, you can see here the sodium iodide symporter. So this sodium iodide symporter brings sodium as well as iodide inside. Now this sodium which came in has to go out, and it utilizes the sodium potassium ATPase pump to go out from it. Okay, and then this iodine which came inside will go into the follicular lumen, and there it, and here TG thyroglobulin will go into the lumen, and then they both will get clubbed together and make the T3 and T4. So I hope this uh, synthesis is clear to you. So now we'll discuss about how this thyroid hormones actually acts. What is the mechanism of action of them? So thyroid hormones actually bind to specific high affinity receptors in the target cell nucleus. T3 binds with approximately 10 times the affinity of T4 that we have discussed. A major effect of T3 and T4 is to enhance general protein synthesis and cause positive nitrogen balance. And these thyroid hormones, like steroids, induce or repress proteins by increasing or decreasing gene transcription. So this is a very much known diagram by you. These thyroid receptors also belong to that superfamily of receptors where all the hormones comes in, right? You already have seen about various hormones. So here also these receptors are there, thyroid receptors, and they get bind with the thyroxine or the T3, and after binding it, that the negative effect or the depressive effect of the thyroid receptors will remove, and they will dimerize and go down. As you have already seen, the dimerization and internalization happens into them, and once they reach into the responsive element, they go and bind with that, and then after binding into that DNA responsive element or the gene, then they do the transcription. They go for the primary transcription, then they form the mRNA, then further protein synthesis. So like that they change everything up to the protein synthesis level. This is another diagram talks about that. You can see the thyroid receptor ligand binding domain, LBD, has been shown. So you can see the nucleus is there, and in these receptors, thyroid receptor ligand binding domain, one co-repressor is there. So one unless until this co-repressor is there, these receptors won't get activated, right? And these are generally the immunophilin proteins or maybe heat shock proteins which are there, and they act there as a co-repressor. In the second diagram, you can see that when the T3, T4 has been released by the thyroid globulin or from the thyroid binding proteins, they bring it to the nucleus, and there T3, T4 released, and this T3 goes in, and this T3 goes in and bind with the ligand binding domain, right? And when it bind with the ligand binding domain, it removes the repressor effect on it, and the activator will get bind with it and make it activated. So once it get activated, it will go and bind with the TRE, and then the changes on the gene will start happening. So this way this whole process happens. So thyroid hormone mechanism of action can be classified into two types. One is genomic or nuclear, and another is non-genomic, including effects at the plasma membrane and mitochondria. Genomic effects involve modification of gene transcription are mediated only by T3. Don't confuse with it. T3 is having the genomic effect and require at least several hours to detect. Non-genomic actions are generally rapid in onset and occur in response to T4 and some T4 metabolites. Got it? So that the physiological role and the other effects has been brought up by the T4. Genomic action of thyroid hormones, if you see, then we can find this that it's similar to the mechanism of action of lipophilic steroid hormones. The lipophilic T3 binds to a protein receptor to form a complex, and the hormone receptor complex binds to an appropriate hormone responsive element on DNA to alter the transcription that already I have shown you in the diagram. We'll see the non-genomic action of thyroid hormone. The non-genomic action may involve interactions with the component of the cellular signal transduction pathway. So it is not directly acting on the gene and changing something, while it is acting on the various components of the cell signaling pathway, such as cyclic adenosine monophosphate CMP or phosphatidylinositol and protein kinases, and there it acts and changes. Examples include effects on cellular respiration, cell morphology, vascular tone, and ion homeostasis. Possible non-genomic targets of thyroid hormone include the plasma membrane, cytoskeleton, sarcoplasmic reticulum, mitochondria, and contractile elements of vascular smooth muscles. Here you can see clearly that the genomic and non-genomic effects of thyroid gland. You can find this T3 and T4. There the T3 acts in the genomic part, acting on the DNA, and here you can see the T4 increases the cell respiration of all foods. Here you can find the glucose, fats, and excess amino acid. It acts on all of them and generates ATP after the process, and then it acts on the bone and muscle, means their effects can be seen on the bone and muscle, liver and viscera, brain, and reproductive organs. Now we'll see some more actions of thyroid hormone. First foremost, growth and development, and second, intermediary metabolism. So let's see in the intermediary metabolism. First, we'll see what they do with the lipid. These are very important effects of the thyroid gland, and lot of side effects or the symptoms of thyroid disorders have been seen because of these things. So what it does to the lipid, T4 and T3 indirectly enhances lipolysis. Keep in mind, indirectly enhances lipolysis. So breakdown of lipid, it increases the breakdown of lipid by potentiating the action of catecholamines and other lipolytic hormones, right? So now to understand this, you remember the effect of adrenergic hormones, what called the receptors, what they do to the lipid, right? So here they are enhancing the lipolysis. They are doing probably by suppressing a phosphodiesterase, increased CMP. You know, this is a mechanism has been shown, right, because it is acting through adrenergic receptors. So while activating that, it increases the CMP, and then plasma free fatty acid levels are elevated. Because of the lipolysis, what will happen? Plasma free fatty acid levels are elevated. Lipogenesis is also stimulated, because once the more breakdown of lipid will happen, then as a positive feedback mechanism, lipogenesis will also start. All phases of cholesterol metabolism are accelerated, but its conversion to bile acids dominates. Thus, hyperthyroidism is characterized by hypocholesterolemia. So this is one of the very important symptom for the hyperthyroidism, that is the hypocholesterolemia. LDL level in blood are reduced. Second effect, this is the effect of this hormone on lipid. Now we'll see the effect on carbohydrate. Carbohydrate metabolism is also stimulated. The utilization of sugar by tissues is increased, mainly secondary to increased BMR. glycogenolysis and gluconeogenesis in liver, as well as fast absorption of glucose from intestine more than compensated. Hyperglycemia will be the result then, because when you have the glycogenolysis, more glycogen will be broken down, so more glucose will form, and gluconeogenesis is also happening. So ultimately, what will the result? Hyperglycemia, and then diabetes like state with insulin resistance occurs in hyperthyroidism. So hyperthyroidism brings the diabetic like state. The effect on protein, synthesis of certain protein is increased, but the overall effect of T3 is catabolic. Increased amounts of protein being used as energy source. Prolonged action results in negative nitrogen balance and tissue wasting. If the effect prolongs, then ultimately the negative nitrogen balance will be created and the tissue wasting will be there. Weight loss is a feature of hyperthyroidism. Why? Because you have seen already what it does to the lipid. T3, T4 in low concentration inhibit mucoprotein synthesis, which is so characteristically accumulates in myxoedema. So that is also the result of the higher concentration of T3 and T4. Also, it does the calorie genesis. Now we'll see the effect on CVS. Again, very important effect of the thyroid gland on CVS observed. Heart rate, contractility and output are increased, resulting in a fast bounding pulse. T3 and T4 stimulates heart by direct action on contractile elements. In the next slide, I'll show you the one mechanism how it happens. Atrial fibrillation and other irregularities are common in hyperthyroidism. Thyroid hormones can also precipitate CHF and angina. Blood pressure, especially systolic, is often raised. Myocardial oxygen consumption can be markedly reduced by induction of hypothyroidism. This one, this diagram, you can understand when the thyroid hormone goes in, it increases the ion channel activity, sodium potassium ATPase activity, as well as reactive oxygen species. So by the oxidative metabolism, once it enters into the nucleus, it go and bind with the thyroid receptor and acts on the gene. After the changing the protein synthesis, it produces various proteins which are doing various effects. For example, ion channel transcription may rise, adrenergic sensitization will be there. It also increases the ryanodine, SCRCA and phospholamban proteins. It also does the contractile functions and hypertrophy by alpha MHC, beta MHC, actin and troponin. So it actually works all around this way, and because of the changing the contractile function, it changes the CVS physiology. Another effect is on nervous system. T through T4 have profound functional effects on CNS. Mental retardation is the hallmark of cretinism. Sluggishness and other behavioral features are seen in myxedema. If you see the cases, there are a huge number of cases. The newly born child are having the irregularities of thyroid gland, and because of that, various mental retardation cases originated. Hyperthyroid individuals are anxious, nervous, excitable, exhibit tremors and hyperreflexia. Another effect on skeletal muscle. Muscles are flabby and weak in myxedema, while thyrotoxicosis produces increased muscle tone, tremor and weakness due to myopathy. Next effect is on GIT. Propulsive activity of gut is increased by T3 or T4. Hypothyroid patients are often constipated, while diarrhea is common in hyperthyroidism. Effect on kidney. T3 and T4 do not cause diuresis in euthyroid individuals, but the rate of urine flow is often increased. when myxoedematous patients are treated with it. Hemopoiesis. Hypothyroid patients suffer from some degree of anemia, which is restored only by T4 treatment. Thus, T4 appears to be facilitatory to erythropoiesis. Reproduction. Thyroid has an indirect effect on reproduction. Fertility is impaired in hypothyroidism and women suffer from oligomenorrhea. Normal thyroid function is required for maintenance of pregnancy and lactation. Now we'll move on to the uses of thyroid hormones. There are drugs which are used in the treatment of hypothyroidism. So here we have levothyroxine sodium, liothyronine sodium, Liotrix, thyroid USP and thyroglobulin. So these are the drugs used for the treatment of hypothyroidism. Later we'll discuss in detail. There are adverse effects of the treatment with thyroid hormone. For example, cardiac palpitations and arrhythmias, tachycardia, weight loss, tremor, headache, insomnia, and heat intolerance are the result of a drug overdose. Symptoms subside if medication is withheld for several days. So, if this symptom comes, we can give a break in between, and then again we can start the treatment. In patients with long-standing hypothyroidism and those with ischemic heart disease, rapid correction of hypothyroidism may precipitate angina, cardiac arrhythmias, or other adverse effects. So, before starting the treatment of these thyroid hormones, the cardiac functions has to be assessed primarily. Cretinism. It is due to failure of thyroid development or a defect in hormone synthesis or due to extreme iodine deficiency. It is usually detected during infancy or childhood, as I already told you that this is nowadays a common condition observed. Treatment with thyroxine daily should be started as early as possible in the case of cretinism. In case of adult hypothyroidism, which is a very common condition, adult hypothyroidism develops as a consequence of thyroiditis, thyroidectomy, or may accompany simple goiter if iodine deficiency is severe. Important drug that can cause hypothyroidism are I311 iodides, lithium, and amiodarone. So these drugs, they can cause these hypothyroidism as well. Treatment with T4 is most gratifying. It is often wise to start with a low dose 50 microgram if one thyroxine daily and increase every 2 to 3 weeks to an optimum of 100 to 200 pg per day. Further dose adjustments are made at 4 to 6 weeks intervals and needed for reaching steady state. Next condition is Edema Coma. It is an emergency characterized by progressive mental deterioration due to acute hypothyroidism, carries significant mortality. Rapid thyroid replacement is crucial. The T3 acts faster. Its use is attended by higher risk of cardiac arrhythmias, angina, etc. Drug of choice is thyroxine, 200 to 500 IV, followed by 100 IV till oral therapy can be instituted. Non-toxic goiter. It may be endemic or sporadic. If it is endemic, due to iodine deficiency, which may be accentuated by factors present in water like excess calcium, food or milk, goitrin, thiocyanate, etc. Means because of these reasons, it may be endemic. A defect in hormone synthesis may be responsible for sporadic cases. In both types, both means sporadic and endemic. Deficient production of thyroid hormone leads to excess TSH. Then what will happen? Thyroid enlarges. More efficient trapping of iodide occurs and probably greater proportion of T3 is synthesized. Enough hormone to meet peripheral demands is produced. Thus, treatment with T4 is in fact replacement therapy in this condition also, despite no overt hypothyroidism. So, I hope you understood why the goiter happens, because there is a deficient production of thyroid hormone. So, what will happen? More TSH will come. For to produce more TSH, more cells has to be formed. So, the thyroid get enlarged. Next is thyroid nodule. Certain and benign functioning nodules regress when TSH is suppressed by T4 therapy. Non-functional nodules and those non-responsive to TSH do not respond. T4 therapy should be stopped if the nodules does not decrease in size within 6 months and when it stops regressing. Papillary carcinoma of thyroid. It is often responsive to TSH. In non-responsive cases, full dose of T4 suppresses TSH production and may induce temporary regression. And the last use here is empirical use. T4 has been sometime used in the following conditions without any rational response is unpredictable. In condition of refractory anemias, menstrual disorders, infertility not corrected by usual treatment, chronic non-healing ulcers, obstinate constipation. So, I hope you understood what are the uses of these hormones are there. Now, we will see the drug interactions. There are very important drug interactions here, keep in mind. Administration of sympathomimetic agents and thyroid hormone to patients means we are giving these two sympathomimetic agents with thyroid hormone to the patient with a coronary artery disease, right? Then what will happen? Increase the risk of coronary insufficiency. Next is, since thyroid hormone increases the catabolism of vitamin K dependent clotting factors, the effect of coumarin anticoagulants may be enhanced. Initiation of thyroid hormone therapy in patients with diabetes mellitus may increase the requirement of insulin or oral hypoglycemic agents. Similarly, a larger dose of cardiac glycoside like digitoxin or digoxin may be required in digitalized patients. So, these are very important drug interaction. We have to be very much cautious while using the other drugs with this particular hormone. So, I hope you understood how this hormone gets synthesized and what is the synthesis process of it, how it releases out, what are the various actions of this hormone, physiological actions, what are the adverse reactions and the uses of this hormone. In the next part, we will discuss about the drugs which are inhibitors of these hormones, right? So, we will discuss about anti-thyroid drugs next. Thank you for watching this video.